but we really do encourage and welcome any feedback and discussion. Ultimately, we're here to engage with you all, and as I said, to start a dialogue. So just thank you for choosing to be here and deciding that this is a topic that's important to you. So with that, I'll kind of jump into our talk, which is titled, Are You in a Blind Spot? And we'll be looking at discrimination within the medical sciences. So science has its own ugly history of racism that you may and hopefully have heard about. These are some of the most infamous incidences of racism that have had a profound effect on the scientific field. For example, here we have the Tuskegee syphilis study, where 600 African-American men had been enlisted to study the effects of untreated syphilis within Black men, in which they were unaware of what was happening to them. Or right here in Canada, where in the 1940s and 50s, Indigenous children in residential schools were used to learn about malnutrition, in which children were denied adequate nutrition and their consent for this study was never obtained. And so these happened within the past 100 years, and hopefully blatant acts of racism like that hopefully wouldn't be tolerated today. But racism and discrimination manifested in other ways is definitely still prevalent throughout the scientific field, and they have profound consequences. Less than 2 weeks ago, an Indigenous woman named Joyce Echequan died while in hospital care within Quebec. She had been admitted to the hospital due to stomach pains, and she was administered morphine despite concerns that she would have an adverse reaction to it due to prior conditions. And so, having experienced mistreatment from hospital staff in the past, she had gone on Facebook Live, and in that video, the healthcare practitioners treating her could be heard insulting her and stereotyping her before her death. And so the circumstances of her death are still being investigated, but this definitely could be a result of the hints of racism and discrimination that live on in our country's healthcare system and STEM as a whole. So as people in STEM, today we really want to talk about how if you're a minority, racism, discrimination, and a lack of diversity will likely affect you, your career, and your healthcare. And if you're a majority, meaning a cis, straight, Caucasian male, we hope that you'll be exposed to some different perspectives and that you'll realize the importance of uplifting the voices of minorities as we really try to bring about change and raise awareness about this. So just kind of some questions maybe to think about. Those would be, how aware are you of the diversity in your own lab, department, or program? Now, Vancouver is pretty diverse, so you might actually notice, like there is a lot of diversity. But how about when you think about the people that you see at conferences, maybe especially the speakers or keynote speakers that you tend to see at these conferences? The second is, do you feel represented in medicine? And what does that even mean, I guess, to be represented in medicine? And lastly is, could doctors, like in your opinion, do you think that doctors could make different medical decisions based on your gender, your race, and your skin color? So kind of just questions to keep in mind throughout the presentation. So let's start with how you'll encounter a lack of diversity throughout your career and what the consequences of that will be. We've all heard about diversity problems in other fields and industries, and surely we think science might be better, right? Well, what I want to show you today is that there's a lack of representation of minority groups. And I really do want to emphasize this point because I don't think it's overly obvious. Like I said before, Vancouver is diverse. So you may look at, the participants in the Zoom call today or your fellow grad students and see that the majority of people are visible minorities. But the problem I'm talking about here really becomes clearer, where as you move up in your career, there's this greater lack of representation of minority groups. And as a result, the consequences of this lack of representation have a greater effect because of how much power these people kind of up here hold. And so I'm going to show data from both academia and industry to back up this claim. And just here, I have an image that's kind of meant to represent like this leadership ladder. And on the left-hand side, I have some common positions within academic institutes. And on the right-hand side are some job titles within industry. And essentially what I'm getting at here is that as you kind of go up this ladder, these positions kind of increase in seniority. And once we kind of get up here, there is a greater disparity in representation of minority groups. So First, we'll look at academia. Remember when I asked you to think about your peers and, kind of how much diversity you may see in your day-to-day in your labs and stuff. Now, I want to kind of like focus on this quote that says, the trainee population is much more diverse than the faculty who train them. And so reading this quote, how does that make you feel? Is this something that you notice when you look at like the PIs in your department, on your committee, or those that you see like pretty often? So research has found that biomedical faculty at research institutes, universities, and medical centers are overwhelmingly white and male. The concerns surrounding this and the strategies for changing this are effectively described in this paper cited here, which is also where the quote is taken from. Granted, this paper was written in a US-based context, but let's look at some data from Canada. So Canada has a program known as the Canadian Research Chairs program, and these are research professorships that are awarded to faculty from post-secondary institutions across Canada. There are two types of research chairs, Tier 1 and Tier 2. Tier 1 is tenable for 7 years, receives $200,000 of annual funding for their institution, and they're described as world leaders within their fields. Tier 2 research chairs, contrastingly, are tenable for 5 years, receive $100,000 in annual funding, and are termed as exceptional emerging researchers. So based on this, Tier 1 is higher up kind of in this hierarchy or that ladder I kind of showed before, because they're for researchers who are further along in their career. And I want you to kind of keep this distinction as mind as we go forward. So let's look at some data now. The Government of Canada publishes stats about the Canada Research Chairs, about their active chairs, and this data was last updated in June 2019. So first is kind of a breakdown of individuals who are research chairs based on the gender that they identify as. You can see in both tiers, the men represented in the red here outnumber women, but there is a greater disparity at the Tier 1 level. Next is the breakdown based on racial identity. So there are three categories here: Indigenous peoples, Caucasian peoples, and visible minorities, in which that's kind of defined as non-Caucasian people, but excluding Indigenous peoples. And again, your Caucasian peoples are the majority, make up the majority in both of these tiers. And lastly, is a breakdown based on whether the individuals identify as having a disability, in which in both tiers, those who do not identify as having a disability are overwhelmingly the majority. So there's a disparity in all three of these categories. And I do think it's interesting to note that the disparity is greater at the Tier 1 level, which, as I mentioned before, is kind of that more senior level, and in both gender identity and racial identity. And to me, like, I would interpret this as being, as you kind of progress along in your career and move up in this ladder or hierarchy into more senior positions, this lack of diversity becomes more pronounced. And so a research chair position is definitely quite prestigious, but it still is a problem in some other positions. From Stats Canada data about Canadian universities and colleges in 2018, visible minorities made up 45% of the grad student population, but only 21% of the faculty population. And so that's summarized kind of in the second source I have down on this slide. And we will have a slide for kind of all the resources at the end. So moving on to industry then, similarly, there's a lack of diversity, especially as you move up the leadership chain. Here, this is data from a report that surveyed 97 biotech companies, including 2 Canadian companies. And when we look at gender, you'll see at the total employee level, it's fairly equal. But as you move up towards like the executive and the board level, the number or the proportion of men definitely start to outnumber the proportion of women. And then the same can be said when we look at racial demographics. The proportion of individuals who are white is closer to a 50-50 split, I guess, at the total employee level, but their proportion of representation increases as you move up that ladder. And outside of Asians here, the composition of other ethnicities is pretty much absolutely dismal, both at the employee level and kind of like the exec and board level. So With kind of those facts out of the way, let's kind of look at what happens when you have a homogeneous group of people at the leadership helm. So first, let's look at like kind of what the leadership team is responsible for. And they're responsible for making decisions, dictating culture and values, and creating and enforcing systems, policies, and group structures. And so the thing is that when we're led by a homogeneous group, all of these parts are being done with like one narrow perspective or being considered through just a single lens. And things end up looking like this. So we have a group of people here who all identify or are being forced to identify as like teal, and they only see things through like this one teal lens. And so the result is that different and important perspectives may be missed out on, and this could result in decisions being made that are harmful to minority groups because they were never considered, such as for decisions within healthcare, or there's a creation of a culture within a workplace that is uninviting for minorities, or there's the implementation of systems and policies that put minorities at a disadvantage. And so I want to go through each one of these 3 points and kind of see how a lack of diversity in the leadership team could affect each one and result in continued discrimination, even if it's unintentional. So first is decision making. The leadership team or any higher ups in any context are responsible for making decisions and like calling the shots. And so this could be about choosing what projects to fund. Sometimes this results in funding projects that are harmful to a group of people, such as the study on malnutrition in residential school children that I mentioned at the very beginning of the talk. So in this case, children were denied adequate nutrition and dental care. And as I said, this had all been done without their consent. And regardless of what the intentions of the study were, there were essentially people who gave this the green light and said that it was okay to do. And I guess just the question I have is like I had for myself was like, why did they think it was okay? Was it because these weren't children from their own communities, so they thought that it was okay to put them through this? It's really a very troubling, like extremely troubling kind of thing to think about. Contrastingly, it could be choosing what projects like not to fund. And this could end up being projects that actually could benefit a group of people. And so this is a paper that has been talked about a lot since it first came out last year in 2019. And so researchers wondered why Black scientists had a lower funding rate for NIH R01 grants, which are the main grants awarded by NIH. And according to the authors, one factor that contributed to this lower funding rate was topic choice. And so topics usually focused on disease prevention and patient-centered care. And of course, topics chosen for funding are dependent on decisions made by reviewers. And out of all the reviewers for the applications looked at in the study, just 2.4% of them 2.4% of the reviewers were Black scientists. And so the point I'm trying to make here isn't that non-Black scientists are outright discriminatory, but that they may not perceive the topics proposed by Black scientists as being as important to study. And the result of this is that we end up having blind spots within our policy and our research, because these are studies that could be really helpful for a particular group of people, but the idea ends up falling through the cracks because it isn't deemed as important by those in power. Moving on now is to culture and values. And so the culture that is created and the values that are held by those in power can really affect your workplace or even the job market. For example, having problematic people in leadership could result in problematic comments that are discriminatory or racist in nature being viewed as acceptable, even if the speaker doesn't necessarily realize it or never had that intention. So you may have heard about this case back in June, but a chem prof from Brock University in Ontario submitted an article to a leading German chem journal that was accepted and published before being retracted. The article essentially criticized diversity hiring. And this is an excerpt from that article in which he says, universities have established various centers for equity, diversity and inclusion, complete with mandatory seminars and training. These issues have influenced hiring practices to the point where candidates' inclusion in one of the preferred social groups may override his or her qualifications. So imagine that this was your own PI or a PI in your department, someone that you see every day who had said this. And now imagine you're a minority. How does it make you feel to know that this is how some people view your achievements? So this essay was published, so clearly enough of the reviewers and editorial board didn't feel like there was anything wrong about what was being said and maybe even agreed with it. Secondly, another example is one that has a larger effect, in which the FBI director agreed with a claim from a US senator that taking in international Chinese students into labs with sensitive information, particularly about things like military technology research, posed a risk for US national security because of the threat of information being stolen. Essentially, a senior member of the US government is warning all businesses to reconsider the hiring of Chinese students. And so statements like these harm Chinese students and could prevent them from being selected for employability because people are going to remember these comments. These xenophobic values held by people in positions of power could affect the entire culture of the US scientific community and how they treat foreign students. Which also influences other Western-centric countries like Canada as well. And lastly, the safety and consideration of underrepresented minorities may not be taken into account, which ultimately leads to a culture of that promotes alienation. And so this article cited here looks at conferences in various disciplines that have chosen a location that is unwelcoming and discriminatory towards LGBTQ+ scientists. Not only are they at a disadvantage because they don't have the opportunity to present their work and network, but they essentially risk incarceration by traveling to these places. And so this is a clear example of decision makers being blind to the needs of the LGBTQ+ STEM community. So the last major thing that the leadership team is responsible for is creating systems, policies, and group structures. So for example, policies could include a company's mat leave policy and how understanding they are to the challenges that are faced by women during their maternity leave and upon returning. Or it could be the hiring practices used and the unconscious biases of the hiring committee, which could unintentionally maintain a homogeneous group of people. So for example, in a book about how students from elite schools and backgrounds get elite jobs, the author noted that candidates in the middle of the decision pile were usually evaluated on 4 additional criteria, in which their race, ethnicity, and gender influenced how much weight each of these additional criteria was given to the candidate. And of course, each group of people evaluated came with their own stereotypes that had been applied by the hiring committee. But now I want to imagine that you're kind of one of the only minorities within a group. You might encounter what psychologists have termed the term solo status. And research has shown that when you're one of few, so those who are under this or experiencing this solo status, you're more likely to perform service duties, which are also known as things that don't actually benefit your career. And it could be things like leading diversity task forces, which a lot of Black, Indigenous, and people of color folks are being asked to do now in their groups since the renewed Black Lives Matter movement, or it could be mentoring other minorities. And all of this has been termed as emotional labor. And so how can we prevent this solo status from happening? So one thing is that leaders could consider changing their hiring practices so that they bring more underrepresented minorities into the group. And so then other minorities might not feel as much of a burden because there's a greater distribution of labor and other people who are similar for them to confide in. And you might ask, like, why is this important? Well, all of this unrecognized labor and all of this emotional labor can be harmful because at what cost does it come from? Ultimately, it takes away from the productive work that matters for career advancement, like research results and progress. So to kind of summarize like my section, I do hope that I've been able to convince you that there is a diversity problem in science, both in academia and industry, and that the disparity of representation of minorities gets worse as you move up into those senior positions. And so think back to your peers again. There's definitely no shortage of smart and capable minority trainees, but the data shows that they're just not being reflected in higher up positions. And so why is this problematic? Well, let's kind of revisit this diagram I showed. Instead of a very monochromatic colorblind perspective like this, that's prone to blind spots and biases in decision making, we essentially want to see a mosaic of colors with unique perspectives, culture, and values. And looking back at the examples I showed, I definitely think that having minorities being part of the decision-making process could have prevented some of those things from happening because minorities really bring their own perspective and help fill in these blind spots. And ultimately, having a diverse spectrum of perspectives is how the scientific field will be most effective because we're addressing the needs of everybody, minorities included. And so this will be reflected in our research and the quality of healthcare that's provided, which is what Josh is going to talk about now. Okay, let me stop my screen sharing.
Okay,
so Josh can hop on.
Tammy, let me just switch on over.
Okay.
Okay, and can everyone see me okay?
Yep.
Okay, so thanks, Tammy. Now, we've talked about how a lack of representation will affect your career, decisions, culture, and systems. But let's take a look at some of the consequences, these blind spots that could affect your health. I'll be splitting my topic into 3 sections. First, I'll be talking about disparities in data sets, followed by education, ending with a direct sample of discrimination within our healthcare. But first, data sets. And let's take a look at the popular data set called TCGA, or the Cancer Genome Atlas. As of 2016, TCGA had over 20,000 samples across 33 cancer types. Now, it's intended to represent the disease among the populace, but how representative do you think this data is? Also, I want to note that we often talk about representation as relative to the population. For example, African Americans make up approximately 12% of the US population, so they should consist of 12% of the data set or clinical trial, or so we also often ask for. This is typically the first and only goal talked about. However, these blind spots, disparities, and passive discrimination is so large, we don't even talk about equal statistical power. But a 2016 study looked at this for 10 cancer types in the TCGA dataset. They wanted to determine the sample size needed to detect moderately common mutations at 10 and 5% frequencies at a 90% statistical power in 90% of genes. Now, this is dependent on the background mutation rate for each cancer type. For example, as the mutation rate increases, so does the sample size you need. But let's check out the results. Here they graph whether each race had a surplus or deficit of samples needed to detect a 10% mutant. Bars above 0 here mean a surplus of samples, while bars below mean a deficit. As you can see, there's only a surplus of samples for white patients, and not for any other minority except cases of Black patients with breast cancer. Most combinations had a deficit of nearly 100 samples or more. This deficit is even more extreme at detection for 5% mutational frequency rate, with white patients in breast cancer receiving in excess of 500 samples. Now, if only that excess was distributed to other races, they could have had proper detection as well. So what does this mean? Well, first, there is variation of cancer among races, and it is probable that ethnic diversity is related to the pathogenesis of cancer, and I'll get to a short example later. But this paper shows that minorities are underrepresented, and essentially do not have anywhere near the same statistical power for documentation of these moderately rare variants compared to white patients. And it means that whole races are functionally invisible for these variants. I say invisible because TCGA is a major resource actively data mined for insights and patterns by decision makers, PIs, etc. This serves as a foundation for guiding future research and treatments. So by having this unequal data set, it can lead to unequal statistical power, which could lead to unequal future treatments. But this racial inequality is not limited to just TCGA. A 2016 analysis revealed that 81% of GWAS participants were of European descent, while only making up about 12% of the population. Now, this is an improvement from the 96% disparity in 2009. However, most of the change was concentrated on Asians, leaving African, Hispanic, and Indigenous people representation essentially unchanged. And let's take a look from a similar analysis. And again, we can see that European descent dominate the chart. But check out the breakdown of the all Asian category. East Asians make up the majority, leaving South Asian representation to a paltry 2% here. This is despite South Asia representing Southeast Asia and the entire Indian subcontinent, which includes nearly 2 billion people, or approximately 25% of the population. Next, depending on the resolution of your monitor, see if you can make out this little sliver of the pie chart here, representing Middle Eastern, Native American, and Oceanic people. Its representation was so small, it couldn't even get a percent representation on this graph for a paper specifically talking about representation. So I will acknowledge there is some progress being made, that GWAS example being one of them, but there is yet another barrier to inclusion of minorities, and that is how the data is used. Because even when we have data from minority groups, many researchers discard them. A Nature article this year attempted to estimate how often minority data is excluded. They coarsely labeled groups as majority and minority from publications that from the UK Biobank and US Retirement Study, which contained about 500,000 individuals. Overall, they found about 45 out of 58 studies excluded the minority group, and 40 out of 41 for the UK Biobank studies. So why does this happen? Well, the first answer is to reduce variables or confounders, but this doesn't mean the data should be excluded. So why don't we just analyze it separately? And often the case is that is possible, but we've shown in our previous slides there are fewer minority samples available, so they have much less statistical power and might not have the same results as your majority cohort. And lastly, it's just more work. So this ends up causing a huge amount of minorities being excluded. And here is an example. For the UK Biobank samples, while minorities make up 5.5% of the total UK population and 5.4% of participants in the UK Biobank, only 0.06% were used in analysis, or a 90-fold reduction. This functionally erases minorities from analysis and research in this context. As I speak to you all as researchers, you know, there is good statistical reason to exclude data, but really just want to highlight the effects of this exclusion. And this is something we just need to be aware of and begin talking about. So that was data sets. Next, I want to talk about how discrimination manifests itself in our education. And I have two examples for CPR and medical imagery. Please see the image below. This mannequin has been adapted to be an anatomical representation of a female. Now, first off, has anyone here ever even seen a female CPR mannequin before? Because I haven't, and I bet you haven't either. Secondly, note where the hands are placed for this life-saving procedure on a female. Have you given any thought to it before? How about what do you do for pregnant women? Well, I'm not qualified to talk about CPR techniques, and yes, there is a slightly different technique for pregnant women, and I encourage you all to look it up. I raise these questions to highlight there's a significant education gap and gender bias in our CPR training, which can have real-world consequences. A 2018 study found that men are more likely to receive CPR in public than women, while no difference was found in CPR administration in the home. This opens up the question of unconscious bias. Is our education biasing people, and in this case, bystanders, to give CPR to men? Would people know to place their hands right over the sternum and breast, just like a male? Or would someone unconsciously compromise this life-saving technique just for the sake of decency? And with this study also mentions that men have a higher overall rate of survival for cardiac events, but I'm going to get into more detail on that later. Next up is medical imagery. So let's play a game. What disease is this? And it's going to be pretty hard to tell on this individual. But how about we show the same disease, but in a white patient? Note the bullseye pattern of the rash here. So maybe some of you might know what this disease is. And it turns out the answer is Lyme disease. But the kicker is for the set of images, one is much more likely to be shown in a medical textbook while the other is excluded. And I think you know which one is more likely to be excluded. It's going to be the melanin-rich individual seen here. Now, this representation extends beyond just textbooks, but to literature, resources, and conferences as well. This has major consequences for your health. Given this bias in representation, a study looked to see if it led to a difference in treatment. This 2000 study saw a higher proportion of African Americans diagnosed later with Lyme disease, and also that African Americans had a higher incidence of Lyme disease-associated arthritis. The authors speculate this may be due to the failure to recognize the disease early on. So not only is Lyme disease harder to diagnose, but doctors might not even be taught how to look for this. So they might subconsciously not even be thinking about this because they're only thinking about, well, do I see a bullseye or not? And this issue isn't just limited to Lyme disease. It could pertain to many, many other dermatological diseases as well. So the question I have to ask is, what other differences in quality and healthcare are looking out there due to this kind of bias or blind spots? And just a few more examples here. Here's Lyme disease again. Note the bullseye rash is kind of present on the melanin-rich individual, but much harder to see, while it's very evident on the white individual. For a more recent example, this is COVID toe. As you can see, one is much harder to see and potentially harder to diagnose versus the white patients. These images come from an international registry for COVID-related skin conditions, and out of more than 700 cases, only 13 Black patients were submitted. And this image was the first image to be submitted into medical literature all the way into July, months and months after the first presentation of the white patients of this COVID toe symptom. So that was education, and now finally on to healthcare. Discrimination is also shows up in clinical trials. Take example, multiple myeloma. It is known to affect African Americans higher per capita than other ethnic groups. Nalarno, for example, was developed as an oral treatment for multiple myeloma, but as you can see, only 1.8% participants were African American. For 31 other clinical trials, only two trials had a 10% African American participation rate since 2015. Remember, that 10% goal is merely meeting a percent representation. Again, we're not even talking about equal statistical power. In conclusion, you can say African Americans are not well represented, and it's only after years of using these treatments can we determine if these drugs are equally performant on African American and other minorities. But how about kidney disease, specifically chronic kidney disease? In chronic kidney disease, the estimated glomerular filtration rate, or eGFR, is used to measure the level of kidney function. But there's a known racial difference in eGFR. It's notably higher in African American and Hispanics. Now, a correction factor is used to normalize this value between Caucasian and African Americans. However, this equation is very simplistic and based on data from a limited number of African Americans. Furthermore, this equation does not take into account multiracial individuals. In the cited paper, the authors decided to correct for this discrepancy, and they used ancestry to reclassify patients. This resulted in 5.3% of participants receiving a different chronic disease staging. So why is this a big deal? Well, staging will affect your treatment and even your placement on a kidney transplant list. Essentially, an oversimplified designation on race could affect your treatment for chronic kidney disease. So I have to ask, how many ways are you out there reduced to some sort of reductive metric or binary yes-no representation? And what are the consequences of that? So imagine, next up, imagine a victim of a heart attack. You know, picture them in your mind. Who and what do you see? Do you see a male clutching their chest? Because if you do, you wouldn't be the only one. And Google Images also seems to agree. Google represents males as a majority of heart attack victims when I just did this Google search, this image search here. Maybe, and can you spot the one female from this result? It's going to be right over here. However, heart attacks are still a major cause of death in women over 65 years of age. It's just that the cardiovascular disease on average happens 7 years later in women than in men. And think back to that CPR slide. I mentioned there was a disparity in survival rates among cardiac events. This gender bias continues to the hospital as well. In a very large Swedish 2017 study that they found there was a survival disadvantage, or rather an increased excess mortality for women versus men. They found that women were receiving differential treatment despite guidelines suggesting equal treatment between genders. Now, Sweden is an advanced first world country, so it's possible these issues are present anywhere in the world. But after this difference was found, there was an adjustment of guidelines, treatments, and education. And with this, excess mortality among women was reduced and found to be not significantly different at 1 year and only slightly higher at 5 years. Now, the paper didn't go into why this differential treatment occurred, but for me, I again thought about unconscious bias. What do you think about for a heart attack victim? And are you confident in your doctor that they're attacking their own unconscious bias when making healthcare decisions? But next is women and pain medication. So a 1987 book discussed the stereotypical viewpoints held by a primary care physician against women. They noted that women were considerably emotionally labile, or more emotional, more apt to exaggerate complaints of pain, and that there's a tendency for them to treat women by prescribing them tranquilizers and sedatives more so than men. A 1990 study in Rhode Island looked to see if this was represented in medical records. They looked at 30 female-male pairs post-coronary bypass surgery, and they found that men received more pain medication than women, while women received more sedatives than men, exactly what that 1987 book was talking about. The study implies that depending on their gender, you might get different treatments. Again, the paper didn't go deeply into why this happened, but it does mention that these prescriptions can be based on the interpretation of your pain by primary care physician or nurses. This could allow for these personal biases and blind spots to affect their decisions. And think about to Joyce Esequan and what biases did those nurses have when they administered their treatment and morphine. So finally, in developing this talk, there are just so many examples of how your race or gender can affect your healthcare that I didn't even have time to give everything justice. But here's just a few more quick examples. For endometriosis, a painful disease for women, diagnosis takes on average 7 to 10 years and is partly based on reporting and that interpretation of pain. Black women are about half as likely to be diagnosed as early as white women, and Asian women are 50% more likely to be diagnosed earlier than white women. Again, about interpretation of your pain, your perspective, and blind spots is shown here to affect diagnosis. EGFR in Asians. Now, this is a different EGFR than mentioned previously. This is for the gene. A mutation in the gene EGFR is associated with non-small lung cell cancer, more often in East Asians compared with their white cohorts. This mutation will affect treatment decisions. So this is one specific example of how cancer pathogenesis can be different among races. But how many other examples haven't been found yet because we just don't have enough samples? CYP2D6 is responsible for 25% of drug metabolism, including the hormone tamoxifen used for breast cancer. There are numerous variants within that gene that are associated with its catalytic activity, represented differently across races. However, your drug dose is largely determined on trials on majority white cohorts that might not be representative of how fast your gene is going to be clearing this drug out of your body. And finally, anti-LGBTQ plus discrimination. Many LGBTQ members have expressed poor treatment from medical professionals as a result of their sexual orientation. This can lead to lack of communication, which can be responsible for poor healthcare, education, screening, and interventions. So I've talked about how discrimination, lack of discrimination, and blind spots can affect your career and health, but let's kind of apply this to one individual, and that's going to be Joyce Eschquan. Now, Joyce's death just shows how she was a victim of a system that negatively affects Indigenous people and minorities. Joyce's death really hits at so many of the points that we're trying to make with this talk. She was part of the, and I can't really pronounce this, the Atikamekw Indigenous group. This Indigenous group in Canada, again, as Tammy mentioned, were subjected to unethical malnutrition study. The Indigenous people are in the blind spot of decision makers that set culture, structures, policies that can negatively affect them. And it's these cultures and structures that all result in poor healthcare for Indigenous people. And let me say, that's just a goddamn understatement for what we're talking about Joyce here, who was essentially yelled at right in her dying hours alone by multiple nurses. And I have to ask, like, how do these multiple bad apples exist? How does a hospital allow for a culture of hate? Well, you know, the Quebec Premier Francois Legault, a leader and decision maker, continues to insist that systematic racism does not exist. Joyce's death speaks to this cycle of poor healthcare that Indigenous people are subjected to and the systematic injustices of our healthcare. And for every Joyce out there, there are many others. But this is why we're here today. This is why we lift up our voices and why, you know, we're here to fight today. Because discrimination is everywhere. It can be present actively or passively, overtly or subversively. It can be systematic and hidden. And it will affect your career and health. But I come to you today to say there is something that we can do about it. So let's talk about how you can affect this lack of representation and these blind spots. Because, you know, 2020 has been a crazy year. And I know everyone's tired, stressed, and filled with this feeling of compassion fatigue. But I just ask you to stay with me just a little bit longer, just please. So what can we do? And I want to emphasize, how can we keep this movement going in a sustainable manner? Well, to me, the first step is acknowledgement. Hopefully we've convinced you that this is a problem. And if you already knew this was a problem, hopefully we've armed you with additional ammunition about the scale, severity, and insidiousness of this issue to help convince others. Secondly, I think it's important to do research and make a habit of thinking about these issues. We all have our own blind spots. And Tammy and I really have learned so much developing these talks. Like most of these examples here, I didn't even know about until I started digging in there. And they're all in plain sight. It's just we are too busy and we don't see them. And what I really want to encourage is to hope you start doing your own research, just little by little, but most really important to just share what you learn. Keep that conversation going. For example, one way you can conduct your research is just try to think about your own research in a discriminatory context. Who's missing in your research? Are the data sets you're using ethnically balanced? Could it affect your results? And lastly, to check out resources and share them with others, including us. But I think what's most important is to just talk. Talk and keep this topic alive and continue the conversation. Talk by discussing problematic behavior and calling it out. The more we do it, the more we can normalize anti-racism. As I mentioned before, you might have to remove statistically underpowered data from minority ethnic groups, but you can document that in your manuscripts and meetings, and you can make a point of it to remind others of this disparity. Also, if you do see any other issues, you can, within PHSA, you can email anonymously at respect@phsa.ca. And feel free to, And lastly, talk because, as Tammy has highlighted, we are filled with blind spots. And if nothing is said, that silence makes you invisible to decision makers and really just affects everyone around. And also just feel free to talk to us. So in conclusion, I just want to take a moment and look at everybody in the chat today. Feel free to emoji or whatnot, but everyone here has taken time out of their busy day to be here and fight against discrimination and educate themselves. So, I want to say on behalf of Tammy and myself, thank you for sharing this time with us and with everyone else. Because although our individual voices are small, I think together we can make a pointed difference, because we're not alone in this fight. We are not alone. Each and every one of us can be influencers. Yes, you there sitting here on the other side of that computer are influencers. You can influence your peers and your PI. You can push for changes that can trickle up through the culture of our healthcare system. And because of the nature of you being grad students, you are decision makers now, and you are future leaders that can help steer policy, systems, culture within your lab and beyond. And so with that, I just want to say thank you again. And I want to give special thanks to Dr. Ali Karsen, who has always been encouraging and supporting of us through our education in this endeavor. Thank you to Angela for organizing this. And lastly, to the Karsen Lab for their support. I just want to also thank you for being here and wish you an absolutely fantastic day. Cheers.
Thank you, Tammy and Josh, for that fantastic presentation. It was thoroughly researched and very thought-provoking. For anyone interested, Tammy and Josh are willing to share their slides. We will make them available on our website as soon as we can, so stay tuned. And thank you to those who asked questions in the chat, and thanks for Tammy for addressing them during the presentation. Feel free to follow up more on those questions if you want to add any details, and everyone else, feel free to speak up and ask any questions, share your thoughts, ideas, suggestions.